Candidates for hormone therapy, again, this requires us taking a deep dive in medical history, personal and family history, what medications you're on. However, if let's say we get through all of that and we say, listen, you're having night sweats, hot flashes, we want to address it, you're low risk, you're up to date with your mammogram, all your other screenings, everything looks great, we want to start hormone therapy. My recommendation is always transdermal estrogen. That would be a patch that you apply to your skin either once or twice weekly. And then we would also add something called progesterone. Now, this comes in different modalities, I guess. Either you would take it orally or you would take it via progesterone IUD. And what's the reason for progesterone versus estrogen? So, progesterone alone is actually fantastic for sleep. It also helps alleviate vasomotor symptoms, those hot flashes or night sweats. There's value in progesterone because it's protective of the uterine lining, right? We want to make sure that that uterine lining stays nice and thin because hypothetically, or not hypothetically, we know that estrogen can actually grow that uterine lining and possibly create an environment where there's precancerous cells, and we just don't want that. However, when we take estrogen, that's really the add back that's going to alleviate those vasomotor symptoms. It's going to help with maybe that frozen shoulder, the joints, the dry eye, gut dysbiosis. So, if we're giving you estrogen, you absolutely always have to have progesterone, unless there's a caveat, unless you don't have a uterus. However, and this is a big however, in my practice, in the way that I practice, I will always give a woman back progesterone for two reasons.